Okay, take two. Lumbar day for 3/4/2020, day of the Final Frontier Npte prep course. Um, so just dig right into it. The first thing that we're going to be looking at is Maggie, 6th edition, chapter 9, focus on figure 911. Okay, so in the lumbar spine, the nerve roots exit through relatively large intervertebral foramina, as in the thoracic spine. Each one is named for the vertebrae above it. In the cervical spine, the nerve roots are named for the vertebrae below it. For example, the L4 nerve root exits between L4 and L5 vertebrae. Because of the course of the nerve root as it exits, the L4 disc between L4 and L5 only rarely compresses the L4 nerve root. It is more likely to compress L5 nerve root. So as you see, L4 disc, L5 disc, back up. L4 vertebrae, L5 vertebrae, and this is L4-5 disc right here. So this is L4 nerve. So compression of L3, L4 is going to compress L4 nerve. Compression of L4 and L5 is going to compress L5 nerve. Okay? L4, L5 disc pathology usually affects the L5 nerve root rather than the L4 root. Okay. So the next thing we're going to do is page 559. So I copied the reading from 559, but there's also a figure on 559. He doesn't really specify what we're supposed to focus on page 559. So we'll do both. Let's start with the figure. Centralization of pain is the progressive retreat of the most distal extent of referred or radicular pain towards the lumbar midline. Peripheralization of pain moves in the opposite direction. So centralization, here's the main spot of the pain. That's where it starts. When it centralizes, it moves from distal to proximal to the primary location of the pain. Distal, proximal. Distal, up towards the main point of the pain. Peripheralization, since the main point of the pain, and then it moves out. It moves down the thigh, down the back of the leg. That's peripheralization. So let's go to the word doc and listen to the reading.
Page 559. Lumbar and sacroiliac pain tend to be referred to the buttock and posterior leg, and sometimes to the lateral aspect of the leg. Hip pain tends to be in the groin and anterior thigh, although it may be referred to the knee, usually medial side. The hip can be ruled out later in the examination by the absence of a hip capsular pattern and a negative sign of the buttock. The examiner must also determine whether the musculoskeletal system is involved or whether the pain is being referred from another structural system, for example, abdominal organs. Abnormal signs and symptoms or red flags, see Table 1 inches, would lead the examiner to consider causes other than the musculoskeletal system. 8. Is the pain deep, superficial, shooting, burning, aching? Questions related to the depth and type of pain often help to locate the structure injured and the source of pain. 9. Is the pain improving, worsening, staying the same? The answers to these questions indicate whether the condition is settling down and improving, or they may indicate that the condition is in the inflammation phase, acute, or in the healing phase. Does the patient complain of more pain than the injury would suggest should occur? If so, psychosocial testing may be appropriate. 10. Is there any increase in pain with coughing, sneezing, deep breathing, laughing. All of these actions increase the intrathecal pressure, the pressure inside the covering of the spinal cord, and would indicate the problem is in the lumbar spine and affecting the neurological tissue. 11. Are there any postures or actions that specifically increase or decrease the pain or cause difficulty? 39. 47. For example, if sitting increases the pain and other symptoms, the examiner may suspect that sustained flexion is causing mechanical deformation of the spine or increasing the intradiscal pressure. 48. Classically, disc pathology causes increased pain on sitting, lifting, twisting, and bending. 49. It is the most common space-occupying lesion in the 1 of 8. Lumbar spine and, therefore, is the most common cause of radiating pain below the knee. If standing increases the pain and other symptoms, the examiner may suspect that extension, especially relaxed standing, is the cause. If walking increases the pain and other symptoms, extension is probably causing the mechanical deformation, because walking accentuates extension. If lying, especially prone lying, increases the pain and other symptoms, extension may be the cause. Persistent pain or progressive increases in pain while the patient is in the supine position may lead the examiner to suspect neurogenic or space-occupying lesions, such as an infection, swelling, or tumor. Remember that pain may radiate to the lumbar spine from pathological conditions in other areas as well as from direct mechanical problems. For example, tumors of the pancreas refer pain to the low back. Stiffness or pain after rest may indicate ankylosing spondylitis or Scheuermann disease. Pain from mechanical breakdown tends to increase with activity and decrease with rest. Discogenic pain increases if the patient maintains a single posture, especially flexion, for a long period. Pain arising from the spine almost always is influenced by posture and movement. The pelvis is the key to proper back posture. Ideally, an individual should be able to stand with the pelvis in neutral. In this position, the anterior superior iliac spines, the scissors, are 1 to 2 finger widths lower than the posterior superior iliac spines, sizes. For the pelvis to sit properly on the femora, the abdominal, hip flexor, hip extensor, and 2 of 8.
Okay, so that was the reading of what was on 559, which is good information. I just think you probably wanted us to focus on figure 912. Okay, so the next thing on the list is table 9.5, page 560. So this is talking about differential diagnosis of mechanical low back pain. We've got muscle strain, herniated nucleus pulposus, osteoarthritis, spinal stenosis, spondylolisthesis, and scoliosis. On the left side, we have age, pain pattern, straight leg raise, and plain x-ray. So for muscle strain, the age is typically between 20 and 40. Pain pattern is in the back. Location is in the back, unilateral. Onset is acute. Standing and bending increase. Sitting decreases. Straight leg raise is negative and plain x-ray is negative. You're not going to detect this on a plain x-ray. Herniated nucleus pulposus, age 30 to 50, location back and leg unilaterally, acute, can have prior episodes. Sitting and bending is going to increase the pain. Standing is going to decrease the pain. The straight leg raise is probably going to be positive because you're impinging on a nerve, and so they will probably have radiating pain from a herniated disc. Osteoarthritis, usually over the age of 50. Back is a location, usually unilaterally. Onset is insidious. It happens over time, progresses over time. Standing is going to increase pain because you're going to be in weight bearing. Sitting and bending decreases weight bearing on the joints, and so it's probably going to decrease the pain. The straight leg raise is probably going to be negative because usually we don't have an impingement of a nerve, and you're going to see it on a plain x-ray. Spinal stenosis over the age of 60. Location is the leg, usually bilaterally. Insidious, it's going to progress over time. Standing is going to increase the pain. Sitting and bending is going to decrease the pain. A straight leg raise is probably going to be positive, and you're going to see this on a plain x-ray. Spondylolisthesis, age 20. Location, back for the pain. Onset is insidious. It happens and progresses over time. Standing and bending is going to increase the pain. Standing and bending. Sitting is going to decrease the pain. Straight leg raise is going to usually be negative, and you're going to see it on a plain x-ray. Scoliosis, age around 30. Location, back. Onset, insidious. Standing and bending is going to increase the pain. Standing and bending. So scoliosis and spondylolisthesis have the same pain presentation. Okay, spondylolisthesis and scoliosis. Scoliosis happens a little bit later in life, so 20 versus 30 in age. Same location, same onset, and same presentation. Standing increases, bending increases, sitting decreases. Straight leg raise is probably going to be negative, and the plain x-ray is going to be, you're going to see it on the plain x-ray. Okay? So there's other things that can differentiate between those two pathologies. We'll get to that. Indications of serious spinal pathology. That's the next thing on the list. Table 9.6, page 566. Indications of serious spinal pathology. Red flags. Presentation younger than 20 and onset greater than 55. Violent trauma such as a fall from a height or a car accident. Constant progressive non-mechanical pain. Can't be changed with a positional change. Thoracic pain. Previous history. Cancer, systemic steroids, drug abuse, HIV. Unexpected weight loss. Systematically unwell. Persisting severe restriction of lumbar flexion. Widespread neurology. Structural deformity. Investigations when required. Sedimentation rate. More than 25 on a plain x-ray. Vertebral collapse or bone destruction. Blood in urine or stools. Cauda-equina syndrome. Cauda-equina syndrome. Widespread neurological disorder. Difficulty with voiding. Loss of anal sphincter tone or fecal incontinence. Saddle anesthesia about the anus, perineum, or genitals. Widespread, more than one nerve root, or progressive motor weakness, the legs, or gait disturbance. Sensory level. Okay, let me make sure I pause this time instead of stop. Okay, and resuming. So I went and looked up a definition for you. Let's move on. Inflammatory disorders, ankylosing spondylitis, and related disorders. Gradual onset before the age of 40 years old. Marked morning stiffness. Persisting limitation of spinal movements in all directions. Peripheral joint involvement. Neuritis. I'm pretty sure that's inflammation of the iris, which is in the eye. Skin rashes, psoriasis, colitis, urethral discharge, and family history. Okay, table 910. So, L1, back over the greater trochanter in the groin. So you can see over here on this picture here. And follow L1. I wish I had a cursor every time I went over a picture. I would like to change about this program. Muscle weakness, none. Reflexes, special tasks, none. Paresthesia, which is tingling, prickling, chilling, burning, numbness. Oh, I need to move my arrow over. No, you move. Come on. Move. Sorry. There we go. Okay. L2, the back, front of the thigh, and the knee. So look over at the picture on the left and see L2, right underneath L1, in between your thighs, right underneath the genitalia, L2, front of thigh to the knee. So you can see over on the back side, in between your legs is L2, L1, and L2. The muscle weakness is going to be the psoas and the hip adductors. So the psoas, which is hip flexion, and hip adduction. Look at the posterior view of the dermatome chart. No reflex test, and you're going to get tingling and prickling, all those paresthesia symptoms, occasionally in the front of the thigh. So with L1, it's going to be groin after holding posture, which causes pain. L2 is occasionally front of the thigh. Let's move to L3, the back, upper buttock, frontal of thigh, and knee. L3, inside of the knee. Inside of the knee. Front of thigh and knee, and medial lower leg. So L3 is going to go all the way down. All the way down. See that medial lower leg? Muscle weakness is going to be the hip flexor psoas, the quadricep, and thigh wasting, L3. The reflex test is the knee jerk. Is going to be sluggish. At the bottom, you see that PKB means prone knee bending. Is going to be positive. And then pain on full straight leg raise. You're going to get the paresthesia, inner knee, and anterior lower leg. Inner knee and anterior lower leg. L3. L4, inner buttocks, outer thigh, inside of leg, dorsum of foot, and big toe. So go over there and follow the L4. Outer thigh comes down, crosses the knee, goes to the medial aspect of the lower leg. Dorsum of the foot and the big toe. So see, L4 is pointing to the great toe, to the medial aspect of the great toe. Your muscle weakness is going to be your tibialis anterior and your extensor hallucis. Extensor hallucis, which is your great toe. Straight leg raise will be limited. Neck flexion pain. Weak knee jerk. And side flexion limited. Medial aspect of the calf and the ankle is where they're going to get their tingling and prickling and their burning and their numbness. Medial aspect of the calf and ankle. L5. Buttocks, back inside of thigh. Let's see where L5 is. Very lateral 5. You can see it on the back, the posterior view of the dermatome chart, L5. Buttock, back and side of thigh, lateral aspect of leg, dorsum of foot. So, see how it comes down towards the intertibialis area, L5, and then it goes down to the top of the foot, inner half of the sole, the bottom of the foot, and first, second, and third toes. So L5 comes down, it wraps around those toes from the top to the bottom of the foot. L5. The muscle weakness is going to be your extensor hallucis, great toe, peroneals, outside of the leg, glute medius, ankle dorsiflexor, hamstrings and calf raising. Ooh, L5. Big one there. Straight leg raise, limited to one side. Neck flexion pain. Ankle jerk decreased. So your Achilles tendon reflex test is going to be decreased. Crossed leg raising pain. Cross leg raising pain. Lateral aspect of the leg is where they're going to feel their tingling and prickling and burning and numbness. And the medial three toes. S1, buttocks, back of thigh and lower leg. Ooh, pretty cardinal. I need to go get some more birdseed. S1, buttock, back of thigh, and lower leg. Okay. Muscle weakness, calf and hamstrings. So posterior leg. Wasting of gluteals, posterior. Peroneals, lateral. Plantar flexors, posterior. S1's all posterior. Except for the peroneals, that's going to be lateral. The straight leg raise is going to be limited. Lateral, two toes, lateral foot, lateral leg to knee, plantar aspect of the foot, lateral, two toes, lateral foot, lateral leg to the knee, plantar aspect of foot, S1. S2, same as S1, dermatome. Same as S1, except the peroneals. You're gonna add the, so S2 is not going to have the peroneals. You're gonna have the calf and hamstring, wasting of the gluteals, and the plantar flexors, but you're not gonna have any peroneal muscle weakness with the S2. The reflex test is the same as S1. Your straight leg raise is going to be limited. And the numbness and tingling is going to be lateral leg, knee, and heel. S3, dermatome, groin, inner thigh to knee, which is really interesting because the dermatome chart doesn't really show that. No muscle weakness, no reflex test, no paresthesia. So the dermatome's groin, inner thigh to knee. S4, perineum, genitals, lower sacrum. S4. Muscle weakness is going to be your bladder and your rectum. No reflex test. The paresthesia is going to be the saddle area, genitals, anus, and impotence. Not good. Okay, so moving on. Let's see, what did we just do? We just did table 910. So now we're moving to table 916. Here, peripheral nerve lesions. Let me pause this for a second. Okay, so I went to my netters and pulled out some pictures. I am a visual learner. I know a lot of people are. So, peripheral nerve lesions, table 916. The nerve root, start with the lateral cutaneous nerve of the thigh, L2, L3. So you can see over there in the picture on the left, the L2, L3 lateral cutaneous nerve coming down the lumbar plexus. In the picture, the leg on the right. In the pink, you can see that the sensory supply is the lateral thigh. Sensory loss is going to be lateral thigh, often intermittent, comes and goes. No motor loss, no reflex change. And the lesion is going to be the lateral inguinal entrapment. So let's go down to the femoral nerve, which is L2 to L4. So L2, L3, L4. And see where it points to as it comes out of the lumbar plexus. The sensory supply is going to be in blue. And the leg picture on the right. Anteromedial thigh and leg. So anterior thigh, anteromedial leg. Anteromedial thigh and leg of the femoral nerve. Sensory loss is going to be anteromedial thigh and leg. Motor loss, you're going to have a decrease plus or minus knee extension, femoral nerve, hip flexion. You're going to have a diminished knee jerk. The lesion is going to be a retroperitoneal or pelvic mass, femoral artery aneurysm or puncture, and diabetic mononeuritis. Sciatic nerve and the posterior cutaneous nerve of the thigh. Let's start with the posterior cutaneous nerve of the thigh. You see in the netter's picture, it's highlighted. It's right next to the sciatic nerve. It's S1, 2, and 3. In the netters, and then in the table, it only says S1 and S2. The sensory supply is going to be the posterior thigh. Look at the blue part on the right leg picture. Posterior thigh sensory loss. Motor loss, none. No sciatic nerve often involved as well. Reflex change, none. Note sciatic nerve is often involved as well. They are right next to each other. The lesion is local buttock trauma, pelvic mass, or hip fracture. Then moving down to the sciatic nerve, we've got L4, L5, S1. And then the netter says L4, L5, S1, 2, and 3. Sciatic nerve. Sensory supply is anterior and posterior leg. So let's look at the, let's look at the pink primarily. the medial sural-cutaneous nerve, the sural nerve. You have the superficial fibular nerve in green, tibial nerve in darker green, and the common fibular nerve in brownish color from the sciatic nerve. All of those come from the sciatic nerve. So the sciatic nerve is going to L4, L5, S1. Sensory supply is anterior and posterior leg. Anterior and posterior leg. It did not say thigh. That is coming from the posterior cutaneous nerve. The sciatic nerve is anterior and posterior leg, sole and dorsum of the foot. Sole and dorsum of the foot. Sensory loss is the entire foot. The posterior cutaneous nerve is the posterior thigh sensory loss. Sciatic nerve is entire foot. Motor loss, you're going to have decrease in foot dorsiflexion, plantar inversion, plantar flexion, and knee flexion. No motor loss with the posterior cutaneous nerve. But with the sciatic nerve, you're going to have dorsiflexion loss, foot inversion loss, plantar flexion, and knee flexion. The reflex is a diminished ankle jerk. And then the lesion, it could be a possible pelvic mass, hip fracture, piriformis entrapment, misplaced buttock injection. Ooh. Okay, moving on. Obturator nerve. L4 to L2 to L4, which is the same on the netters. Obturator nerve. Look how it passes into the, I forget what that's called. The pelvic circle. Passes in between there. Obturator L2, L3, L4. Sensory supply is medial thigh. Look at the leg picture to the right, and you'll see the blue area, medial thigh, where the adductors are. Sensory loss, often none. I'm not sure what they mean by plus or minus, but medial thigh, I guess, can be or more sensory or less sensory. Medial thigh. I'm not sure what they mean by that. Motor loss is thigh adduction. Reflex change, none, and lesion would be a pelvic mass. The common fibular perineal nerve, L4, L5, S1, S2. Division of the sciatic nerve, anterior leg, dorsum of the foot. So, the common perineal nerve. Anterior leg and the top of the foot. Sensory loss, none, or dorsal foot, top of the foot. Motor loss, dorsiflexion, inversion, and eversion. Note, a positive Tinel sign at lateral fibular neck. Reflex change, none. Note, a positive Tinel sign at lateral fibular neck. Lesion, entrapment, pressure at neck of fibula. Rarely, diabetes, vasculitis, leprosy. And these are the two tables together, table 910, table 916. And I added another picture from Netters. I like this bottom part of the picture. Segmental innervation of lower limb movements. Hip flexion, L2, L3. Hip extension, L5, S1. Knee extension, L3, L4. Knee flexion, L5, S1. Dorsiflexion, L4, L5. Plantar flexion, S1, S2. Inversion, L4, L5. Eversion, L5, S1. Kind of looks like a swing. kind of swings, you know, hip flexion, L2, L3, hip extension, L5, S1. It skips L4 in the hip. Extension, knee extension, L3, L4, flexion, L5, S1, dorsiflexion, L4, L5, plantar, S1, S2, inversion, L4, L5, eversion, L5, S1, like that. So if you notice that it's the hip again that skips L4. Well, why is that? So L4 doesn't really act on the hip. Inner buttocks, outer thigh, inside of leg, dorsum of foot, and big toe. Pretty cool. Okay, moving on. So now let's go back up here. And we did table 910 and 916. And now we're to the grades of 628. Here, 628. So this is the grading system for slippage in spondylolisthesis. Spondylolisthesis. I'm going to stop here and see if I can find some description in here. Okay, I went and looked at the books. I couldn't find any verbal descriptions of these grades. But I know we had one in school. You notice how far the slippage is. So you have grade 1, grade 2 is 2, grade 3 is 3, and grade 4 has 4. So I wish I could find some better descriptions. I could probably go to my school books. Here, let me pause this again and see if I can find it. That's really bothering me. Okay, so I went and pulled some stuff from school. So osis is a pathologic condition, lysis is a break, and listhesis is a slippage. Spondylosis, degenerative changes affecting the disc, lumbar bodies, and associated joints of the lumbar spine. Non-specific term, osteoarthritic changes as a result of aging that causes bony spurs, decrease in intervertebral space, and lumbar disc degeneration. Synonymous with arthrosis, spondylitis, hypertrophic arthritis, and osteoarthritis. So that's spondylosis. Gradual onset with progressive worsening of radicular symptoms and morning stiffness. Symptoms generally improve throughout the day with movement. Certain positions increase pain, which can lead to discomfort at night. Etiology. Aging phenomenon that progressively increases with age presents 27 to 37% of asymptomatic population. More than 80% of individuals over 40 have lumbar spondylosis. Approximately 84% men, 74% women develop lumbar spondylosis at T9 and 10 and L3 levels. Etiology. Age is the strongest risk factor for bony degeneration. Studies found risk factors increasing from 0 to 70% between the ages of 39 and 70. This degeneration increased from 16% at age 20 years to 98% at age 70. Osteophyte formation has strong correlation with increasing age. Activity and occupation, BMI, back trauma, daily spinal loading, whole body vibration. Increased likelihood and severity of spondylosis. Hereditary genetic factors influence the formation of osteophyte and disc degeneration. Studies found 50% of variability found in arthritis attributed to heritable factors. Those are osteophytes. Ouch. Spondylosis, a defect of the pars interarticularis of the spine. Broad range of etiology, stress fracture to traumatic bone fracture. Can progress to lithesis if both pars are involved on both sides. Exact known cause can be congenital, acquired from repeated microtrauma, or developmental causes. Again, lysis is a break, lithesis is a slippage, osis is a pathologic condition. There's the pars articularis. This is spondylosis, spondylolysis, which is a break. Spondylolysis is a break in the pars articularis. Okay, and that shows a spur of the bone and narrowing of the disc. Another MRI. Intervention, surgical intervention for this condition can be performed when radicular symptoms become severe. Non-surgical interventions are often successful in managing symptoms and in restoring function. Motor control retraining and stability exercises are often implemented to reverse postural and mechanical changes. Manual techniques, including mobilization, are also frequently used to restore mobility. Spinal mobilization therapy has been found to be significantly more effective in the reduction of radicular symptoms. And here we are to spondylolisthesis. Anterior slippage and inability to resist shear force of the vertebral segment in relation to the vertebral segment immediately below it. Most common area is L5S1, as you see in the picture. Leads to spinal instability, can be congenital, defect in pars, degenerative, traumatic, or pathologic, caused by surgical disruption of ligament, bone, and disc. Spondylolisthesis, graded according to the percentage of slippage. This is what I was trying to find for that picture that we had way up there. So graded according to the percentage of slippage. Distance from line from posterior cortex of S1 body to the posterior inferior corner of L5 vertebrae. So distance from line from posterior cortex of S1 body to the posterior inferior corner of the L5 vertebrae, divided by the anterior posterior diameter of the sacrum. Classification is grade 1, 1 to 25%, grade 2, 26 to 50, grade 3, 51 to 75, grade 4, 76 to 100, and grade 5, 100%. So, go up here, I copy that slide, and down to here. Is that it? Nope, here. What is that, slide 27? Let's come up here. Go here. Stay there, and I'm going to bring slide 27. Got it. Pull this one over and make it a little bigger. Okay. So those are the grades. Five grades. Grade 1, up here, 1 to 25%. Grade 2, 26 to 50%. Grade 3, 51 to 75. Grade 4, 76 to 100. And then grade 5 is 100%. We're in trouble. Okay. out of that. Clinical presentation is back or buttock pain, pain that runs from the lower back down or one or both legs, numbness or weakness in one or both legs, difficulty walking, leg back or buttock pain that gets worse when you bend over or twist. Bend over or twist. Loss of bladder and bowel control in rare cases. Let's see. Let's copy that. And I'll put a picture. I love pictures. I really do. I really do love pictures. Over and move this. Okay. So it gets worse when you bend over and twist. So bending over, pain. Yeah. Bend over and twist. Okay. There's your grades again. Grade 1, grade 2, grade 3, grade 4. Ouch. Let's copy paste that. And there you go. That's better. Picture. All right. Clinical presentation. All right. Moving on. So, let's see. I go to the top here. So we did the grades. Now we're on table 918. Differential diagnosis of lumbar strain and posterolateral lumbar disc herniation at L5 to S1. History. Lumbar strain. Mechanism of injury. Side flexion, side flexion, and rotation under load or without control. That's the mechanism of injury. Flexion, side flexion, and or rotation under load or without control. Lumbar disc, L5 to S1. Quick movement into flexion, rotation, side flexion, or extension. May or may not be under load. Pain in lumbar spine may be referred to buttocks. May increase with extension, muscle contraction, or flexion, muscle stretch. For the lumbar disc in lumbar spine, with referred to posterior leg to foot radicular pain. So you have radicular pain. Increases with extension. Observation. Scoliosis may be present, muscle spasm. Lumbar disc. Scoliosis may be present, muscle guarding. Active movement. Pain, especially on stretch, flexion, side flexion, and rotation. Pain on unguarded movement and limited range of motion. Lumbar disc. Pain, especially on extension and flexion. Extension and flexion for the lumbar disc versus pain, especially on stretch, flexion, side flexion, and rotation. So strain is when we flex, when we stretch it, and then lumbar disc is pain on extension and flexion, depending on where the disc is protruding. Resisted isometric movement, pain on muscle contraction, often minimal pain. Myotomes are normal. The lumbar disc, minimal pain unless large protrusion. L5S1 myotomes may be affected. Special tests. Neurological tests are negative. With the lumbar disc, straight leg raise, and slump tests are often positive. Sensation with the lumbar strain is normal. With the lumbar disc, L5S1 dermatomes may be affected. Reflexes, lumbar strain, they are normal. With a lumbar disc, L5S1 dermatomes may be affected. Oh, no, that's sensation. Reflexes, L5S1 reflexes may be affected. Joint play, lumbar strain, you'll have muscle guarding, and with lumbar disc, you'll also have muscle guarding. Okay, so we're moving to the green, Kisner, 7th edition, chapter 15, table 15.2, and the readings, page 467 to 469. Table. And put the table in there. Okay, so there is no table 15.2 in Kisner textbook. That's why I didn't have it in my PowerPoint. Must be a typo because there's none there in the 7th edition. And it wasn't in the reading folder as well. So I took pictures sent pictures out of the book for the reading, and this here is just redundant. It's just pictures of the stuff in the book. So we don't need to go through that. So what we're going to do now is go ahead and pull up the reading folder and get the iPad to read it to us.
Page 467-469 Management Guidelines. Flexion bias. Patients may present with a flexed posture and be unable to extend because of increased neurological symptoms and decreased mobility. These patients would benefit from early interventions that emphasize flexion of the involved segments to relieve symptoms. The patients may have a medical diagnosis of spondylosis or spinal stenosis, central or lateral, an extension load injury, or capsular impingement or swollen facet joints, so symptoms increase with extension. The flexed position reduces or relieves the symptoms. Note, cervical radiculopathy is discussed in the section on management of regional diagnosis later in this chapter. Principles of management. Physical therapy interventions focus on increasing the diameter of the foramen and minimizing nerve root irritation. Effective position. Flexion widens the IV foramina, whereas extension decreases the size of the foramina. Any compromise of the foraminal opening, such as encroachment from bony spurs or lipping of swollen tissue, reduces the space. The patient may describe intermittent nerve root symptoms, intermittent numbness or tingling, and if the involved segment extends, indicating mechanical compression. Constant nerve root symptoms could be caused by inflammation and swollen tissue. 3 of 8. Effective traction. Traction has been demonstrated to widen the IV foramina. Positioning the spine in flexion prior to the application of traction provides the greatest increased space. Positional traction, in which the patient is placed inside bending away from the side of pain and rotation toward the pain, may also be beneficial to increase the diameter of the lateral foramen. 3-4 of 8. Effect of trauma and repetitive irritation. Swelling in the facet joints from macrotrauma or microtrauma leads to a compromised foraminal space. With degeneration and increased mobility in a spinal segment, instability could be the cause of repetitive microtrauma, leading to swelling and pain. Effect of meniscoid tissue. The meniscoid tissue of the joint capsule may become impinged with sudden movements. This blocks specific movements, such as extension and side bending to the involved side. Manipulation and traction usually relieve the symptoms. Indications and contraindications for intervention. Flexion approach indications. Flexion is used if neurological and/or pain symptoms are eased with flexion and worsened with extension positions or motions. Contraindications, extension with rotation positions, motions, and exercises are contraindicated if neurological symptoms or pain worsen with these motions. Flexion exercises are contraindicated if neurological or pain symptoms peripheralize with flexion or repeated flexion maneuvers. See box 15.9. Techniques utilizing a flexion approach in general. Spinal flexion postures and exercises are taught following the guidelines described in boxes 15.5, 15.7, and 15.8. The following suggestions should also be considered for special conditions. 4-5 of 8. Management of acute symptoms. Patient education as described in the general acute section earlier in this chapter. Once the functional position for comfort is identified, encourage the patient to move within pain. Free ranges and maintain daily activities that do not exacerbate the symptoms. Passive support, such as use of a cervical collar or lumbar corset, is typically not utilized or discussed with the patient except when managing patients with RA or other disorders associated with hypermobility or instability. Functional position for comfort for flexion bias in the lumbar spine. The position is usually with the hips and knees flexed so the lumbar spine flexes in the cervical spine. The position is toward axial extension. Upper cervical flexion, with some flexion also in the lower cervical region if there are neurological signs. The position provides maximal opening of the IV foramina to minimize impingement of the nerve root. Traction, gentle intermittent joint distraction and gliding techniques may inhibit painful muscle responses and provide synovial fluid movement in the joint. For healing, dosages must be very gentle, grade I or II, to avoid stretching the capsules and are best applied with manual techniques during the acute stage with spondylosis or stenosis. If a patient does not have signs of acute joint inflammation but does have signs of nerve root irritation, stronger traction forces may be beneficial to cause opening of the IV foramina. It helps relieve the pressure. 5-6 of 8. Contraindication. If a patient has RA, traction and joint mobilizations, manipulations in the spine are potentially dangerous because of ligamentous necrosis and vertebral instability, therefore, they should not be performed. Correction of lateral shift. If the patient has a lateral shift of the thoracic region along with symptom relief when in flexion, he or she may be taught self-correction. Patient position and procedure. Standing with the leg opposite the shift on a chair so the hip is in about 90 degrees of flexion. The leg on the side of the lateral shift is kept inflated. Have the patient then flex the trunk onto the raised thigh and apply pressure by pulling on the ankle. Figure 15.9. Correction of meniscoid impingements. If there is entrapped synovial or meniscoid tissue in the facet joint that blocks motion interextension, release of the trapped meniscoid relieves the pain and the accompanying muscle guarding. The joint surfaces need to be separated and the joint capsules made taut. General techniques include traction and manipulation. Traction to the spine may be applied manually or mechanically. The patient also can be taught self-traction and positional traction techniques. Traction applied longitudinally along the axis of the spine has the effect of sliding the facet's joint surfaces and thus placing tension on the facet capsules. Traction with contralateral side bending and rotation of the spine has the effect of distracting the facet joint surfaces as well as placing tension on the capsules. Techniques of manual traction, self-traction, and positional traction with rotation and manipulations are described in the stretching section of Chapter 16. 7 of 8. Management when acute symptoms have stabilized. General guidelines for subacute and chronic spinal problems are summarized in boxes 15.7 and 15.8. Specific emphasis when treating patients with mobility impairments due to hypomobile or hypermobile facet joints should include the following. Hypomobile joints require stretching but not if the techniques stress a hypermobile region. Traction techniques may be effective if the hypermobile region is stabilized during stretching. For those trained in joint mobilization manipulation techniques, These techniques are effective for selective facet joint stretching and have been found to be an effective part of a total treatment approach when there is instability in specific areas and restricted mobility in neighboring facet joints. Emphasis is on developing dynamic stability through muscle control in the hypermobile regions while gaining mobility in the restricted regions. Strength and flexibility of the trunk, hip, and shoulder girdle musculature requires elective stretching and strengthening. If there are bony changes and osteophytics occurs, the patient should avoid postures and activities of hyperextension, such as reaching or looking overhead for prolonged periods of time. Adaptations in the environment might include using a step stool so reaching is at shoulder level. Postures and motions emphasizing flexion of the spine that increase the size of the IV foramina are usually preferred for patients with RA. Emphasis is on stabilization and control. Because of the potential instabilities from necrotic tissue and bone erosion, subluxations and dislocations may cause damage to the spinal cord or vascular supply and can be extremely debilitating or life-threatening. 8 of 8.
And I'm going to pause there so I can go let my dog out. Okay, so I know this video is getting a little long, but we are going to go through the the Kisner chapter 15, 467 to 469. Again, repetition. Best for learning. Here we go.
Page 559. Lumbar and sacroiliac pain tend to be referred to the buttock and posterior leg, and sometimes to the lateral aspect of the leg. Hip pain tends to be in the groin and anterior thigh, although it may be referred to the knee, usually medial side. The hip can be ruled out later in the examination by the absence of a hip capsular pattern and a negative sign of the buttock. The examiner must also determine whether the musculoskeletal system is involved or whether the pain is being referred from another structural system. For example, abdominal organs, abnormal signs and symptoms or red flags, see Table 1 inches, would lead the examiner to consider causes other than the musculoskeletal system. 8. Is the pain deep? Superficial, shooting, burning, aching? Questions related to the depth and type of pain often help to locate the structure injured and the source of pain. 9. Is the pain improving, worsening, staying the same? The answers to these questions indicate whether the condition is settling down and improving, or they may indicate that the condition is in the inflammation phase, acute, or in the healing phase. Does the patient complain of more pain than the injury would suggest should occur? If so, psychosocial testing may be appropriate. 10. Is there any increase in pain with coughing, sneezing, deep breathing, laughing? All of these actions increase the intrathecal pressure, the pressure inside the covering of the spinal cord, and would indicate the problem is in the lumbar spine and affecting the neurological tissue. 11. Are there any postures or actions that specifically increase or decrease the pain or cause difficulty? 39. 47. 1 of 13. For example, if sitting increases the pain and other symptoms, the examiner may suspect that sustained flexion is causing mechanical deformation of the spine or increasing the intradiscal pressure. 48. Classically, disc pathology causes increased pain on sitting, lifting, twisting, and bending. 49. It is the most common space-occupying lesion in the lumbar spine and, therefore, is the most common cause of radiating pain below the knee. If standing increases the pain and other symptoms, the examiner may suspect that extension, especially relaxed standing, is the cause. If walking increases the pain and other symptoms, extension is probably causing the mechanical deformation, because walking accentuates extension. If lying, especially prone lying, increases the pain and other symptoms, extension may be the cause. Persistent pain or progressive increases in pain while the patient is in the supine position may lead the examiner to suspect neurogenic or space-occupying lesions, such as an infection, swelling, or tumor. Remember that pain may radiate to the lumbar spine from pathological conditions in other areas as well as from direct mechanical problems. For example, Tumors of the pancreas refer pain to the low back. Stiffness or pain after rest may indicate ankylosing spondylitis or Schumann disease. Pain from mechanical breakdown tends to increase with activity and decrease with rest. Discogenic pain increases if the patient maintains a single posture, especially flexion, for a long period. Pain arising from the spine almost always is influenced by posture and movement. 2 of 13. The pelvis is the key to proper back posture. Ideally, an individual should be able to stand with the pelvis in neutral. In this position, the anterior superior iliac spines, scissors, are 1 to 2 finger widths lower than the posterior superior iliac spines, sizes. For the pelvis to sit properly on the femora, the abdominal, hip flexor, hip extensor, and 2-3 of 13. Page 467-469 Management Guidelines. Flexion bias patients may present with a flexed posture and be unable to extend because of increased neurological symptoms and decreased mobility. These patients would benefit from early interventions that emphasize flexion of the involved segments to relieve symptoms. The patients may have a medical diagnosis of spondylosis or spinal stenosis, central or lateral, an extension load injury, or capsular impingement or swollen facet joints. So symptoms increase with extension. The flex position reduces or relieves the symptoms. Note, cervical radiculopathy is discussed in the section on management of regional diagnosis later in this chapter. Principles of management physical therapy interventions focus on increasing the diameter of the foramen and minimizing nerve root irritation. Effective position. Flexion widens the IV foramina, whereas extension decreases the size of the foramina. Any compromise of the foraminal opening, such as encroachment from bony spurs or nipping of swollen tissue, reduces the space. The patient may describe intermittent nerve root symptoms, intermittent numbness or tingling, and if the involved segment extends, indicating mechanical compression. 4 of 13. Constant nerve root symptoms could be caused by inflammation and swollen tissue. Effective traction. Traction has been demonstrated to widen the IV foramina. Positioning the spine in flexion prior to the application of traction provides the greatest increased space. Positional traction, in which the patient is placed inside bending away from the side of pain and rotation toward the pain, may also be beneficial to increase the diameter of the lateral foramen. Effective trauma and repetitive irritation. Swelling in the facet joints from macrotrauma or microtrauma leads to a compromised foraminal space. With degeneration and increased mobility in the spinal segment, instability could be the cause of repetitive microtrauma, leading to swelling and pain. Effective meniscoid tissue. The meniscoid tissue of the joint capsule may become impinged with sudden movements. This blocks specific movements, such as extension and side bending to the involved side. Manipulation and traction usually relieve the symptoms. Indications and contraindications for intervention. Flexion approach indications. Flexion is used if neurological and/or pain symptoms are eased with flexion and worsened with extension positions or motions. 5 of 13. Contraindications, extension and extension with rotation positions, motions, and exercises are contraindicated if neurological symptoms or pain worsen with these motions. Flexion exercises are contraindicated if neurological or pain symptoms peripheralize with flexion or repeated flexion maneuvers. See box 15.9. Techniques used.
So, there's box 15.9, contraindication to specific spinal movements. Extension of the spine is contraindicated when no position or movement decreases or centralizes the described pain. When saddle aphasia and or bladder weakness is present, could indicate spinal cord or cauda equina lesion. When a patient is in such extreme pain that he or she rigidly holds the body immobile with any attempted correction. Flexion of the spine should be avoided when extension relieves the symptoms, when flexion movements increase the pain or peripheralize the symptoms. Box 15.9.
Utilizing a flexion approach in general, spinal flexion postures and exercises are taught following the guidelines described in boxes 15.5, 15.7, and 15.8. The following suggestions should also be considered for special conditions. 6 of 13.
Okay, so here is 15.5, acute spinal impairments protective phase. Impairments, activity limitations, and participation restrictions. Pain and or neurological symptoms, inflammation, guarded posture, prefers flexion, extension, or non-weight bearing, limited ability to perform ADLs and IADLs. Plan of care, educate the patient, decreased acute symptoms, teach awareness of neck and pelvic position and movement, demonstrate safe postures, initiate neuromuscular activity and control of stabilizing muscles, teach safe performance of basic ADLs and progress to IADLs. So, engage the patient in all activities to learn self-management, inform the patient of anticipated progress and precautions. To decrease acute symptoms, we're going to use modalities, massage, traction, or mobilization, manipulation as needed. Rest only for a couple of days if needed. Teach kinetic training, cervical and scapular motions, pelvic tilts, and neutral spine. Neutral spine. Practice positions and movement and experience effect on spine. Help patient find the functional spinal position of comfort in supine sitting and standing. Deep segmental muscle activation techniques include lumbar spine, drawing in maneuver, multifidus contraction, cervical spine, gentle head nod, basic stabilization with arm and leg motion, passive support if needed, progress to active control. Roll, sit, stand, and walk with safe postures. Progress tolerance to sitting longer than 30 minutes, standing longer than 15 minutes, and walking around a mile. Okay, that's box 515. This is box 15.7. But not that big. There we go. Okay. So, box 15.7, management and guidelines, subacute spinal problems, controlled motion phase. Impairments, activity limitations, and participation restrictions. Pain, only when excessive stress is placed on vulnerable tissues. Impaired posture, postural awareness, impaired mobility, impaired muscle performance, poor neuromuscular control of stabilizing muscles, decreased muscle endurance and strength, general deconditioning, limited ability to perform IADLs for extended periods of time, and poor body mechanics. Plan of care, educate the patient in self-management and how to decrease episodes of pain. By engaging the patient in all activities, emphasizing safe movement and postures, develop a home exercise program, teach ergonomic adaptation of work and home environment. Progress awareness and control of spinal alignment. Practice active spinal control in pain-free positions and with all exercises and activities. Practice posture correction. Increase mobility in restricted muscles, joint, fascia, and nerve. Joint mobilizations and manipulation, neuromobilization, muscle inhibition, and self-stretching. Teach techniques to develop neuromuscular control, strength, and endurance. Progress stabilizing exercises, increase repetitions, emphasize muscle endurance. Initiate extremity strengthening exercises in conjunction with spinal stabilization. develop cardiopulmonary endurance. Low to moderate intensity aerobic exercises emphasize spinal bias. Teach techniques of stress relief and relaxation exercises and postural stress relief. Teach body mechanics and functional adaptations. Practice stable spine lifting, pushing and pulling, and reaching practice activities specific to desired outcome, emphasizing spinal control, endurance, and timing. Box 15.8. Chronic spinal problems return to function phase, impairments, activity limitations, and participation restrictions. Pain only when excessive stress is placed on vulnerable tissues in repetitive or sustained nature for prolonged periods. Poor neuromuscular control and endurance in high intensity and destabilized situations. Flexibility and strength imbalances. Generalized deconditioning. Limited ability to perform high intensity physical demands for extended periods of time. Plan of care. Emphasize spinal control in high intensity and repetitive activities. Practice active spinal control in various transitional activities that challenge balance. Increase mobility in restricted muscles, joints, fascia, and nerve. Joint mobilization, manipulation, neuromobilization, muscle inhibition, and self-stretching. Improve muscle performance, dynamic trunk and extremity strength, coordination, and endurance. Progress dynamic trunk and extremity resistance exercises, emphasizing functional goals. Increase cardiopulmonary endurance. Progress intensity of aerobic exercises. Emphasize habitual use of techniques of stress relief, relaxation, and posture correction. Motions and postures to relieve stress. Teach safe progression to high-level, high-intensity activities. Apply any ergonomic changes to work or home environment. Teach healthy exercise habits for self-maintenance. Progressive practice using activity-specific training consistent with desired functional outcome, emphasizing spinal control, endurance, balance, agility, timing, and speed.
Management of acute symptoms. Patient education as described in the general acute section earlier in this chapter. Once the functional position for comfort is identified, encourage the patient to move within pain free ranges and maintain daily activities that do not exacerbate the symptoms. Passive support, such as use of a cervical collar or lumbar corset, is typically not utilized or discussed with the patient except when managing patients with RA or other disorders associated with hypermobility or instability. Functional position for comfort for flexion lies in the lumbar spine. The position is usually with the hips and knees flexed so the lumbar spine flexes in the cervical spine. The position is toward axial extension, upper cervical flexion, with some flexion also in the lower cervical region if there are neurological signs. The position provides maximal opening of the IV foramina to minimize impingement of the nerve root. Traction, gentle intermittent joint distraction and gliding techniques may inhibit painful muscle responses and provide synovial fluid movement in the joint. For healing, dosages must be very gentle, grade I or II, to avoid stretching the capsules and are best applied with manual techniques during the acute stage with spondylosis or stenosis. If a patient does not have signs of acute joint inflammation but does have signs of nerve root irritation, stronger traction forces may be beneficial to cause opening of the IV foramina. It helps relieve the pressure. 8-9 of 13. Contraindication. If a patient has RA, Traction and joint mobilizations manipulations in the spine are potentially dangerous because of ligamentous necrosis and vertebral instability, therefore, they should not be performed. Correction of lateral shift. If the patient has a lateral shift of the thoracic region along with symptom relief when in flexion, he or she may be taught self-correction. Patient position and procedure. Standing with the leg opposite the shift on the chest so the hip is in about 90 degrees of flexion. The leg on the side of the lateral shift is kept extended. Have the patient then flex the trunk onto the raised thigh and apply pressure by pulling on the ankle. Figure 15.9.
Okay, it looks like I have the wrong. So let's go to the PowerPoint. Figure 0.9. Oops. And so I don't know about you, but I've never heard of this before. Standing with the leg opposite the shift on a chair so the hips are in about 90 degrees of flexion. So the leg opposite of the shift is on the chair. Okay. The leg on the side of the lateral shift is extended. Okay. Have the patient then flex trunk onto the raised thigh and apply pressure by pulling on the ankle. Interesting.
Correction of meniscoid impingements. If there is entrapped synovial or meniscoid tissue in the facet joint that blocks motion interextension, release of the trapped meniscoid relieves the pain and the accompanying muscle guarding. The joint surfaces need to be separated and the joint capsules made taut. 10 of 13. General techniques include traction and manipulation. Traction to the spine may be applied manually or mechanically. The patient also can be taught self-traction and positional traction techniques. Traction applied longitudinally along the axis of the spine has the effect of sliding the facet's joint surfaces and thus placing tension on the facet capsules. Traction with contralateral side bending and rotation of the spine has the effect of distracting the facet joint surfaces as well as placing tension on the capsules. Techniques of manual traction, self-traction, and positional traction with rotation and manipulations are described in the stretching section of Chapter 16. 11 of 13. No speakable content could be
Having issues here.
No speakable content could be found on the screen. No speakable content could be found on the screen.
Okay. Management when acute symptoms have stabilized. General guidelines for subacute and chronic spinal problems are summarized in boxes 15.7 and 15.8. So is that what we already went over? Box 15.7 and 15.8. So we already went over those. I'm not going to go over those again. No, we are not. This video is already really long. Okay, so let's go ahead and do this one.
Specific emphasis when treating patients with mobility impairments due to hypomobile or hypermobile facet joints should include the following. Hypomobile joints require stretching, but not if the techniques stress a hypermobile region. Traction techniques may be effective if the hypermobile region is stabilized during stretching. For those trained in joint mobilization manipulation techniques, these techniques are effective for selective facet joint stretching and have been found to be an effective part of a total treatment approach when there is instability in specific areas and restricted mobility in neighboring facet joints. Emphasis is on developing dynamic stability through muscle control in the hypermobile regions while gaining mobility in the restricted regions. Strength and flexibility of the trunk, hip, and shoulder girdle musculature require selective stretching and strengthening. If there are bony changes and osteophytic spurs, the patient should avoid postures and activities of hyperextension, such as reaching or looking overhead for prolonged periods of time. Adaptations in the environment might include using a step stool so reaching is at shoulder level. Postures and motions emphasizing flexion of the spine that increase the size of the IV foramen are usually preferred for patients with RA. Emphasis is on stabilization and control. Because of the potential instabilities from necrotic tissue and bone erosion, subluxations and dislocations may cause damage to the spinal cord or vascular supply and can be extremely debilitating or life-threatening. Specific emphasis when treating patients with mobility impairments due to hypomobile or hypermobile facet joints should include the following. Hypomobile joints require stretching but not.
Okay, so there you go. So that was chapter 15th of the Keisner 467 to 469. There's pictures of those pages. Those are the boxes that they talked about in the figure, and that is just redundant from the beginning. And so that concludes day 26 for March the 4th, Wednesday, and we are going to hour and a half. All right.